ان شاء الله النهارده هيكون في حالات بريزنتد من جامعه المنصوره فولو اب، وبرضه من مركز اورام جنوب مصر، وبرضه حاله من الدكتور عاطف من مستشفى مصر للقاهره. يعني اتفضلوا يا دكاتره.
السلام عليكم. أنا منار حامد، مدرس مساعد ميديكال أونكولوجي سنتر منصورة يونيفرسيتي. هعمل بس سكرين شير عشان أعرض الأبديتس بتاعت الحالة اللي فاتت. هي الحالة اللي احنا عرضناها امبارح قصدي البورد اللي فات، يعني كانت a case of a male patient 40 years old. They can presented with bilateral neck and right axillary swelling that dated 1.5 years ago. He didn't have these symptoms and his medical, surgical and family history were irrelevant. He did the BAN-CT assessment, which was stage 2 lymphadenopathy above the diaphragm. Excision of the right axillary lymph node was done, and it was the malignant large round cell tumor consistent with the plasmacytoma. It was positive CD138, focal positive MBO, and Ki67 was 70%. MOM1 was positive, and the rest of these markers, including CD20, BCL6, CD30, CD56, CD79A, were negative. Kappa and lambda was unfit for interpretation. Bone marrow and bone marrow aspirate and biopsy assessment showed about 5 to 10% of plasma cells of the total cellularity positive CD138. IBT didn't show any abnormal cell. His labs were accepted. He didn't show CRAB criteria, and SPEB was normal. Our decision was to treat him as lymphoblasmacytic lymphoma. He received 4 cycles of shock. CT showed regression, then continued further 2 cycles. Then he did PET-CT infiltrates at excisional biopsy, and it gave pretty much the same diagnosis. Recurrent plasmacytoma in the axillary lymph node. Again, positive CD138, negative CD20 and CD90 and CD79A. In the last board, you suggested to do further immunohistochemistry to exclude the possibility of being a solid tumor, and do some melanoma, some carcinoma, some smooth muscle markers, and also do further immunohistochemistry to detect the lineage of the cell, like CD30, CD39, 38, CD43. Of course, all these markers will do a lot of marker on expense because we didn't want to add further financial toxicities than the patient already has. So we did LCA, EMA, CD138, and MOM1, and they all were positive, while BAX5, S100, HMB45, Milan8, Desmin, Vimentin, Cyclin D1, CD30, HHV8, and BCL6 all were negative. He also did the free Kappa light chain serum was modest elevation 19.8, and the free lambda light chain was 29.6, and the IgM were normal. The pathology came with a differential diagnosis to us. It's query plasmacytoma or plasmablastic lymphoma. You assess and clinically and correlate clinically and radiologically with the patient. The patient clinically had excellent performance, and he was also asymptomatic. He seems to me like a plasmacytoma case or lymphoblasmacytic lymphoma, something more indolent and less aggressive than plasmablastic lymphoma. You also asked for IBT on lymph node. This technique is still developing at our center. They still have a lot to learn, still figuring things out as regard the proper keeping tissue preservations and stuff. So the final report was inconclusive. Well, I looked for a few case reports of primary plasmacytoma involving multiple lymph nodes. There were about, what I could find, were about 8. The last 2 here were localized. and they could be treated by involved field radiotherapy or excision with يعني اللي عملت excision آخر واحدة دي was in CR but اللي أخدت radiotherapy was incompletely reported, so we don't know what she did after that. While those with disseminated lymphadenopathy, most of them were treated with chemotherapy like Indoxan, Dexa, Shop, chlorambucil, prednisolone. The first case here received involved field radiotherapy and didn't achieve any responses, so it received second line as a case of multiple myeloma, received the VTT based in O2, then lenalidomide maintenance, and achieved the CR for about 18 months. So, what do you think, Dr. Muhammad?
هو احنا المعلومات ديت مفيده دلوقتي. الفكره الدايجنوسيس اللي احنا هنقف عليه وهنكونفيرم التريتمنت according to هيبقى ايه. لو احنا if we are treating it as a plasma blastic lymphoma that has failed prior therapy with R-CHOP, I believe 8 or 9 cycles. It's difficult ان احنا نقول بالضبط التريتمنت according ده، بس يعني لو الدايجنوسيس is fitting more for a plasma blastic lymphoma، يعني دي مش I don't know. I'm not leaning to the words إن هي تبقى plasmacytoma of lymph node, unless Dr. Al-Quran معنا, he's the chief of hematopathology and the director of the lab here. If he has any comments on the new findings, طبعا تبقى حاجة مفيدة الأول قبل ما نتكلم على التريتمنت نفسه.
Yes, Dr. Muhammad. Yeah, I think the problem for this case, like to me, the diagnosis, these are not conclusive and the diagnosis is not confirmed yet. You know, based, I guess, on the initial discussion from last time, CD138 is a marker specific for plasma cells within the hematopoietic system. However, it can be expressed in carcinomas, melanomas, and lymphomas. So based on the previous phenotype, MUM1 was positive. I mean, that kind of takes out the carcinomas and sarcomas, but melanomas can be still positive for it. I mean, the most definitive marker for plasma cells would be kappa or lambda. I mean, this can be done either by immunohistochemistry, which is cheaper, or by in situ hybridization. So I have you. I mean, the other point I want to make is about the bone marrow findings. 5 to 10% plasma cells in the marrow, that's high. Were these plasma cells tested for kappa or lambda light chain restriction? I mean, that's an important question to answer, because that may indicate the presence of plasma cell disease or not.
No, they weren't done from the bone marrow.
Yeah, so that needs to be done. The other thing is, this patient immune compromised or not?
No.
Okay. Because you know, you have the 80-20 rules for the plasmablastic lymphomas. Yes, you can see them in non-immune compromised patients, but it will be nice to demonstrate the expression of EBER, for example, or EBV. Was that evaluated?
HHV8.
But the EBV, the EBER stain.
EBV was not, no.
Yeah.
No, it wasn't.
Now, you talked about an indolent process. A lymphoplasmacytic lymphoma would have a B cell component and a plasma cell component, and it would not have a Ki67 of 70%. With lymphoplasmacytic lymphomas, you can have increased large cell scatter, but it should not be 70%. So there is a lot of, you know, we are like missing some pieces for the puzzle. You know, the PAX5 negativity definitely goes with, you know, normal plasmacytomas would expect them to be negative. I mean, you essentially ruled out a melanoma, but it's LCA positive. EMA, you know, even though it's reported, we really don't rely on it. I mean, we rarely use it in our practice. but so far you have markers for MUM1, CD138, and LCA. These are markers you see with normal plasma cells, not the malignant plasma cells. So it will be helpful if you had like some pictures to look at. Now, the phenotype, or that if you can get hold of that file, it's like electronic file, because it looks like you have a very comprehensive panel when you talked about the immunophenotyping. And I just want to.
هو clinically he presented a generalized lymphadenopathy.
No, it's the neck, both groups, and in the right axillary lymph node.
Okay. يعني مفيش lymph nodes below the diaphragm.
No.
مفيش حاجة في الchest.
No.
Yeah.
Okay, we'll try to do Kappa and Lambda, and we'll see. Thank you. Any comment? Any further comment?
لا بصراحة ما عنديش other comments. دكاترة.
Yeah, as I said, like if you can get hold of the electronic file for the flow cytometry, you can email it to me. I'm more than happy to look at it, because before the meeting I was discussing a case with Dr. Higazi and show him what can be done. But so far, everything points out, you have 50% cells that are 19, 38, 138. Every points out to a plasma cell proliferation or new plasma.
دكتور منار، هو العيان البيوبسي بتاعته الليمف نود البلوك بتاعتها موجوده؟
Of course so.
اوكي. يعني دكتور سامر ممكن نبقى يعني keep me in the loop as well. يعني if we reach a dead end and if there's a way to get the blocks here. يعني كان في دكتور مصري pathologist he offered يعني to do some if we send him the block he could help with the workup. لان هي مشكله هنا في الدايجنوسيس. فلو يعني لو ادينا يعني treatment recommendations بس الدايجنوسيس questionable هتبقى يعني مش صح يعني.
And how symptomatic the patient is, Manar?
He is asymptomatic.
He's asymptomatic. طب كويس الحمد لله. يعني ما احناش we are not in a rush to make any decisions right now until the diagnosis is reached عشان برضه التريتمنت يبقى appropriate. أنا عايز أقول لك يا دكتورة منار والناس اللي في الحضور، يعني الاوفر بتاع الدكاتره سواء الفلو سايتومتري، دكتور سامر القرآن he's an expert flow cytometrist. يعني الحاجات اللي هو بيعملها with flow cytometry is beyond any standard lab هنا في اليونايتد ستيتس حتى with flow. and والاوفر بتاع الدكتور سامح، الدكتور شريف اللي هو الباثولوجيست يعني he's willing to do those things. take him on it وتيك advantage لو الحالات فعلا محتاجه it will make a difference in their treatment. يعني ويبقى سعداء جدا يعني لو في communication حصل في هذا والايميلز هتكون متواجده للاورجنايزرز بتاعت الايفنت ان هو لو حد عايز يتواصل نتواصل عن طريق ده ان شاء الله. اوكي.
اوكي. تاني حد معانا دكتور عاطف موجود؟
ان شاء الله.
اوكي انا هعمل ستوب شير اهو، وانت اعمل شير من عندك بقى.
اهلا وسهلا دكتور عاطف.
دكتور محمد، ازي حضرتك؟
الحمد لله بنعم الحمد لله. اتفضل شير السكرين وبعد كده ابتدي البرزنتيشن بتاعتك.
حاضر. معلش في تكنيكال ايشوز بس ثواني. طيب ممكن حد يبدأ مكاني على ما اظبط مشكلة السكرين شير دي؟
ممكن لو دكتورة
رحاب سكرين شير انا مثلا وتقول لي نيكست سلايد اقلب لك انا. خلاص
لا معلش، لو حد تاني يبدأ على ما اجهز بس السكرين شير، انا ما اعرفش ايه
طيب ماشي.
طب ثواني.
هو انا موجوده يا جماعه، لو انتوا عايزين ان انا ابدا اوكي. انا بالنسبه
يا
لي
ريت يلا نبتدي نبقى كده المرحله الثانيه.
طيب تمام اوكي. استاذنكم بس انت خلاص قفلتي السكرين، ثانيه واحده. تمام، شايفين يا دكاتره كده؟ انا عملت شير سكرين، شايفين ولا ايه؟
لا انا لسه السكرين مش متغير عندي. لا
تمام كده ولا ايه؟
مش شايفين بقى.
مش واضحه برضه.
لا هو مفيش، السكرين مش شيرد عندي.
لسه يا رحاب. لا تمام. طب وكده؟
لا برضه مفيش حاجة.
برضه عشان انا داخله من الموبايل
طب ثواني انا معايا الحاله بتاعتك يا دكتور رحاب، انا هعمل لها شير و
هقرا من عند حضرتك. تمام.
هي دي الحاله مظبوط؟
بالظبط كده.
اتفضل.
بسم الله الرحمن الرحيم. أنا رحاب حسن، مدرس طب الأورام وأمراض الدم السرطانية في معهد جنوب مصر الأورام. بحب أرحب بحضراتكم جميعا. برحب بالدكتور سامر، دكتور طارق طبعا، منورنا يا دكتور. يعني فرصة سعيدة جدا إن أنت تحضر معانا. أبدأ ربنا يخلي حضرتك يا فندم. بسم الله الرحمن الرحيم. الحالة اللي عندنا يعني اللي هي السهل الممتنع، هو male patient 65 years old, retired, hypertensive on medical treatment from 10 years with history of transient ischemic attack on May 2014. On February 2020, patient presented by weight loss, easy fatigability. CBC was done, showed marked leukocytosis with shift to the left up to 5 plus cell. Bone marrow aspirate and biopsy was done. Can CML in chronic phase. BCR able was positive in fish by 50%. استاذنك يا دكتور محمد اللي بعديها. دكتور محمد بعد اذن حضرتك تغير سلايد. البيشنت received Glevic 400 mg daily and has complete hematological response after 3 months. ووصل complete molecular response on October 2020 when a PCR was not detected في blood test. The patient after that started to lose his molecular response by increase a PCR بتاعه in March 2021. It was 0.021% with normal CBC. Patient continued on Glevic until August 2021 when PCR increased up to 0.9%. When he started Takacida on September 2021, no bone marrow aspirate or biopsy was done, no molecular study was done. CBC, all that was normal and no blood cell could be detected. استاذ حضرتك دكتور محمد.
دكتور رحاب انا عندي سؤال، هو في اي ستاديز غير البي سي ار was done على لما when it started rising في February of 2021
مثلا cytogenetic مثلا او molecular changes او كده ولا ايه؟
يعني tyrosine kinase domain mutation analysis مثلا؟
حاجه لا حضرتك ولا حاجه، هو اصلا غير التريتمنت، كان كل الفولو اب بتاعه بالبي سي ار وعلى اساس غير التريتمنت يعني. قال ان هو حضرتك بدا في سبتمبر 2021 بدا التسجنه. بدا المفروض هو كان بادئ على 800 per day، وبعدين في نوفمبر 2021 البيشنت suddenly had heaviness of speech, hemiparesis. MRI brain was done, relieved small abnormal signal intensity seen في left parietal and left frontal area, intense and flare with restricted DWI, suggestive a subacute small infarction. CBC also was normal, but the BCR was 1.1. The patient stopped the signal from December 2021 due to his medical condition and received the medical treatment at neurology department. he discharged after 2 weeks of admission. 2 days later, a patient at home presented by vomiting, disturbed conscious level. Urgent CT was done, relieved acute subdural hemorrhage in occipito-parietal region of his right side. بعد إذن حضرتك السلايد اللي بعديها. All lab was normal. CBC, PT, BC, INR, all were normal. Patient received medical treatment, then discharged for just physiotherapy at home. Last PCR on January 2022 was 9.3. يعني ده في شهر واحد من stopping of Takacida. Questions بعد إذن حضرتك السلايد اللي بعديها. Questions لحضراتكم. Which is the best treatment for this case according to his medical condition, and which the optimal dose? If there is a role for anticoagulant in his situation with a history of stroke and hemorrhage with TKI, does Takacida has a role in his condition? بعد إذنك دكتور محمد، رأي حضرتك إيه في الحالة؟ العيان ياخد إيه؟
انا ليا اراء في كذا حاجه، بس انا هستنى اسمع من الدكتور سامح رايه في الموضوع الاول.
اتفضل يا دكتور.
وطبعا الدكتور طارق شاركنا بعده برضه.
تمام. هو يعني السي ام ال طبعا يعني انا مش توتالي فوكست عليها، بس يعني هو في بعض الحاجات. هو انا بس دكتور حابب هو في مصر ميوتيشن اناليسيز على البي سي ار ولا الاي بي ال، ولا مش افيلبل؟
ما سالتش حقيقه بصراحه، انا ما سالتش، وانا حتى بس ايفن مستغربه ان العيان ما تعملوش حتى بون مارو اسبريت بايوبسي مع انكريز البي سي ار. هو العيان بصراحه يعني برايفت، هو يعني بيتعالج برايفت عند حد وسالوني فيه، فحبيت اخد راي حضراتكم في العيان لان في كذا راي.
هو لو العيان هنا حضرتك يعني هو اتليست هنعمله بس بون مارو بايوبسي نشوف هل يعني هو في chronic phase accelerated. هو it sounds like هو still is in chronic phase، بس البون مارو اتليست يعني just to confirm ان هو في chronic phase. بالنسبه الميوتيشن اناليسيس لو مش موجود، انا يعني it might be good يعني just to ask يعني if it's available or not، لان هو ممكن يساعدك في التشويس. هل فعلا لان خلي بالك برضه هو ساعات العيان بيبقى من non compliant، يعني ممكن يبقى هو يعني البي سي ار بيعلى لان هو simply ما بياخدش جليفيك او النلاطه طبعا has been off عشان لو جاله الستروك. انما الميوتيشن اناليسيس ساعات بيساعد في القصه دي برضو، وبيساعد كمان في التشويس.
تمام. انا استاذ حضرتك بس في عدم وجود دراج اصلا في انا الميوتيشن معايا قوي في الافيلبل دراج اللي عندي، يعني انا عندي الافيلبل عندي الكليفيك تسجنا سبرايس يعني زي
اوكي يعني ما دول مش وحشين، دول حلوين قوي. بالظبط. بس هو يعني الميوتيشن اناليسيس ممكن يساعد ننقي انا واحد فيهم، لان هو لو فعلا عنده ريزيستنس مش كلهم بيبقوا يعني ممكن تلاقي مثلا في بعضهم بيبقوا ريزيستنت ل all of these 3. يعني لو عنده مثلا T اللي هو الاي 315 اي ده هيبقى يعني هيبقى ريزيستنت للثلاثه دول، يعني ده هيحتاج بوناتنب. انما في other mutations يعني ممكن مثلا تلاقي حتى جليفيك احسن من التزاتنب، ممكن تلاقي التزاتنب احسن من نلاطنب في حاجات، فهو it depends على بس لو مش موجود خالص we're absolutely sure يعني. يعني هو مش ريفراكتوري للنلاطب، يعني هو وقفه بس عشان قصه الستروك. هو it sounds like العيان عنده مشاكل اصلا، يعني كان عنده يعني TIA يعني قبل ما ياخد التسجنة، ف it's very possible ان الستروك اللي جات له هو عنده underlying. يعني مثلا هل مثلا بصينا على الاتريوم بتاعه، هل بصينا على الكاروتيدز، هل في يعني عنده AFib مثلا عشان كده بيجيله يعني جاله الستروكس. انما ستروك وتحولت لهيموراجيك it does not necessarily have to be nilotinib. طبعا البوناتنب لا يعني associated اكتر مع vascular events، انما النلاطنب هي it's not impossible, it's there but it's low, it's like 1 to 2%. ف يعني I think يعني if you يعني I would do a bone marrow biopsy if there is mutation analysis, do it. لو ما فيش يعني أنا I think يعني it's reasonable to maybe restart it at يعني يمكن حتى يعني a lower dose وبعد كده go up. بس I would do like a full neuro workup ونشوف يعني هل الستروك ديت هل ليها سورس ولا لا، هل عنده AFib ولا لا، هل عنده يعني atrial clot مثلا ولا لا، عنده مثلا carotid stenosis وفيها plaques ومحتاجه تبقى stented ولا لا. انما يعني it's rare not impossible but it's rare to be ان اللطم بيبقى الكوز يعني.
فهمت رأي حضرتك ان هو يكمل عليه بذا سيم دوز بعد نبدا
بس يعني
مثلا.
زي ما قلت لك يعني لو كملنا بس يعني نفنش بس الورك اب يعني بنقول البون مارو بايوبسي ونورك اب الستروك يعني ايه ليه جاله ستروك يعني، ولا هي يعني ايديوباثيك فور شور يعني.
لا هو حضرتك سوري دكتور محمد اكسبلين الموضوع. بعض دكاتره العصبيه كانوا شايفين ان هو حصل له هايبوتنشن فحصل فيها حاجه اسمها زي اسكيميك ستروك، وبعدين لما خرج حصل هايبرتنشن عشان هو في الاسكيميك ستروك بيحبوا البلاد بريشر بيكون يعني على الابر ليميت، فقالوا ان هو زاد شويه بسيطه فحصل له هيمورج. والاقاويل تختلف طبعا، حضرتك عارف يعني اختلاف الدكاتره.
هو
بس
الووتر شيد ستروكس اللي بتحصل مع الهايبوتنشن، بس هو ايه جاله يعني ايه سابسز يعني وكان هايبوتنسيف ولا جاله هايبوتنشن من ايه؟
لا خالص ولا اي حاجه خالص، ده هم على كلام دكاتره العصبيه ان هي فيها زي وايت شادو كده في الام ار اي، فده موستلي ده بيحصل مع الهايبوتنسيف ستروك الاسكيميك ستروك، ده على كلام الدكاتره بتاعه العصبيه بصراحه. فهو احنا المشكله ان هو يعني البي سي ار بتاعه في حوالي شهر زاد حضرتك من 1.1 لحد 9%، فانا شايفه ان هي زياده برضه بصراحه كبيره.
لازم نعمل بون مارو طبعا بس نتاكد ان هو مش اكسلريتد فيز يعني برضه هيكون حلو. رايك ايه يا محمد؟
ماشي دكتور محمد اتفضل.
والله انا عندي كذا نقطه. دكتور طارق في اي نقط حابب؟
لا انا اعتقد ان هو يعني maybe I missed that بس هو جاله stroke even before the diagnosis of CML صح؟
بالظبط
يعني هو من الاول عنده مشاكل تانية يعني بس I agree with دكتور سامح يعني طبعا احنا بنعمل هنا routinely mutational analysis يعني لو مش موجود طبعا the goals of care هنا are very important to discuss with the patient يعني what's his performance status what's the goal لو هو هيكمل بقى ب complications كده هو يعني whether it's from treatment or other comorbidities we يعني he needs يعني you need to clarify with the patient the goals of care and هو ممكن يعني you can keep him or your threshold for achieving complete molecular response ممكن يتغير based on his performance status.
مظبوط. انا بس في كذا نقطه. هو في كم حاجه كده انا بحب اعملهم، انا بعملهم من باب الاكسرسايز دايما بعملهم مع الفيلوز لما بيجي حالات السي ام ال الجديده. بنكالكوليت سكورز كده، هي اكتر في الكلينيكال ترايلز يوز اكتر ما هي في الحقيقه، بس برضو بتخلي الاحساس بالintensity of the disease or the risk of this CML لان not all CML chronic phase are the same. في low risk, intermediate risk and high risk based on these are not 100% agreed upon. بس سواء مثلا انا بحب calculate السوكال سكور على الاقل on diagnosis. اللي بيقول لي الاول هل imatinib is my way because I بحب استخدم imatinib ما زلت. I prefer to use imatinib for front line unless there's something telling us otherwise اللي هو لو high risk CML from the get go. والhigh risk CML comes in with certain numbers. بالسوكال سكور دوت بيبص على السبلين سايز، البليتلت كاونت، البيشنت's age ويطلع لك السكور. انا ما شفتش المعلومات ديت فما اقدرش اكالكوليت سكور right now. I agree طبعا في النقطة اللي هو once you start seeing a loss of a major molecular response الميوتيشن التيروسين كاينيز mutation domain analysis plays a role. دلوقتي أنا لو لقيت إن التيروسين let's assume إن إحنا عملناه and we did not find a mutation, would I have switched the patient from imatinib? Maybe not. أنا ممكن برضو نزود الدوز بتاعت الإيماتينب to 600 ونكمل المونيتورنج بتاعنا في هذا الموضوع ومش محتاجين إن إحنا ننقل على التسجنة. أنا أكتر حاجات اللي لما بتجي لي حالات من دولت اللي هو بلاقي العيان circle through 3 or 4 TKIs within 6 months for reasons or not. فدي حاجة. الحاجة الثالثة ودي مهمة جدا ألا هي إيه الأدوية الثانية اللي المريض بياخدها غير أدوية الضغط اللي هو عليها. هل بياخد اي مثلا PPI او اي انتاسيد او اي حاجه؟ لان دولت بيقللوا الابسوربشن بتاع الادويه دي جدا، وياما عيانين became resistant للادويه ديت مش بسبب ان هم resistant للدواء، ولكن لان الدواء اصلا is not absorbed appropriately. فلو العيان بياخد بروتونكس ولا اوميبرازول ولا لانسوبرازول ولا بيبسيد كتير وكده، ممكن يؤدي ان الابزوربشن بتاع الدواء يقل، ويؤدي ان الريسبونس بتاعه يروح. I agree with دكتور سامح بنقطة إن الانسيدنت بتاع السيريبروفاسكولار اكسيدنتس في الستروك في التسجنة is reported not to be very high. أنا مش عارف العيان دلوقتي حالته عاملة إيه؟ يعني هل هو النيورولوجيكال دامج ريكفرد ولا لسه؟
هو حضرتك الكونشوس ليفل ريكفرد، بس العيان ستيل هيميبليجيك اندر، يعني في ريسبونس شويه، بس مش الريسبونس اللي هو زي الاول طبعا، لا العيان ستيل هيميبليجيك بس اندر فيزيوثيرابي.
So dense hemiplegia جنب منه لسه واقف يعتبر. هو يعني انا هنا بقى هتيجي اللي هي النقطه اللي هو انا I wouldn't roll the dice للتسجنة تاني بصراحه يعني. انا هخاف ان انا اروح، بالذات لو احنا ما قدرناش نلاقي سبب للستروك. لو ما قدرناش نلاقي سبب للستروك أخاف إن يكون هو دوت واحد من ال 1% أو ال 2% اللي ممكن يكون بيجي لهم الحاجة دي، لأن هو كوموربيد أوريدي. العيان جاي لنا أوريدي بهايبرتنشن وتي اي ايز سنين قبل الدايجنوستس، ولكن ده مش معناه إن هو مش هيرسبوند to the other therapies اللي عندنا، سواء بين السبرايسل اللي موجود أو الهاير دوز imatinib اللي هو قاعد عليها مشوار we went from undetectable to 0.9%، وساعتها التريتمنت سويتشد. ومن غير ما نبص نشوف اذا هو اصلا ريزيستنت ولا كانت زي ما دكتور سامح ودكتور طارق قال الكومبلاينس بتاع الدواء بتاع المريض للدواء مهم جدا جدا جدا. وده اول سؤال دايما لازم نساله قبل ما ننقل الدواء، وبعد كده الريزيستنس، وبعدين الاذر كوموربيديتيز والميديكيشنز بتاعتهم، ونشوف بقى لو ساعتها النقل متطلب ولا لا. هو قعد مده اعتقد سنه صح؟ بيست على حاله هنا سوري، هو قعد زي diagnosed ديت كانت في شهر 2 2020 ونقل وهي بيكيم بوزيتيف شهر 3 21، فقعد حوالي سنه على الجليفك. ف يعني في امل. يعني انا بحب اللي هو بمسك في الدواء وافضل ماسك فيه unless ان في سبب يخلينا انقل منه either with toxicity او resistance، لان الجليفاك has a very 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 long history مع في التريتمنت بتاع المرض ده، والسكسس بتاعه كان بي sometimes you have to بس يعني ايه تعملي تغييرات بسيطه وتلاقي الريسبونس كان بي obtained، especially انه زي ما الدكاتره قالوا it's not acting like an accelerated phase، لان السي بي سي was maintained completely normal حتى لما البي سي ار became positive. فالانتي كوجوليشن الديسيجن ده عاده دوت انا مش ما بتدخلش فيه، لان دوت مهم جدا النيورولوجيستس هم اللي يقولوا لنا هم ايه رايهم الاوريجين بتاع الستروك دوت، هل دوت شخص دلوقتي محتاج يبقى على انتي كواجيليشن ولا لا. احنا عيانين التي كي ايز مش محتاجين يبقوا على اي حاجه من البلاد ثينرز، انما الستروك نفسها والشات فاسك سكور بتاعته والكالكوليشنز بقى ما اعرفش، انا متخيل مش عارف ليه انا تخيلت ان هو عنده اي بصراحه يعني. بس ده اللي هو هتعرفوا منه الانديكيشن والرول بتاعها. الهيموراجيك كونفرجن is not unheard of. it's a complication بتحبن في عيانين الاسكيميك ستروك، لما especially لما الستروك تكون مغطيه منطقه كبيره بتحصل، وعشان كده البرميسيف هايبرتنشن اللي هم كانوا عايزينه وعايزين يحافظوا عليه it's a good idea. بس دي الكام نقطه اللي انا كنت عايز اضيفها.
طب يا دكتور محمد بعد اذن حضرتك، احنا كنا زمان بصراحه بنقرا ان هو المفروض اول حاجه بنشوف فعلا الكومبلاينس بتاع العيان لو احنا شفنا لوس للريسبونس بتاع الجريفيك، والحاجه الثانيه ممكن بنشوف زي ما قال برضه الدكتور سامح وزي ما قلت لحضرتك ان في دراجز بتاثر على الابزوربشن، فقالوا ان احنا ممكن نعمل الليفل اوف جليفيك في البلود. هل ده ابليكابل فعلا بيتعمل ولا ده
الليفل بتاع التي كي اي
ليفل اوف
ما هوش ستاندردايز، ما فيش ستاندرد. يعني انا ام نوت اوير اوف ان حاجه هتجيب لك ستاندرد اللي هو المريض دوت الليفل بين كذا وكذا يو هاف تو اتشيف ات. مش يعني unless الدكتور سامح او الدكتور طارق عندهم حاجه، مش عندنا حاجه بالشكل ده يعني we don't do it.
طيب حضرتك دكتور سامح حضرتك عندك فكره عن الكلام ده ولا مش؟
لا انا ما عملتهاش. احنا عاده بنشوف الاناليسيس او زي
تمام. طب بالنسبه لمعظم فعلا ان بيكون عندها سفير جاسترايتس وكان مكتوب ان هو مثلا H2 بلوكر it is more effect على الابسوربشن بتاعه، بس لو كده يبقى ياخدوا غالبا البي بي اي وياخدوا ديفرنس مثلا ساعتين قبليها، فهل الكلام ده صحيح ولا يبقى اصلا العيان مش هيعيش برضه بجاسترايتس وجاستريك ابسيت على طول من الديزي من الدراج يعني؟
هي مشكله التسجن ان هو توايس جاي صح؟ فهي مشكلته بالجاسترايتس كده هتعملي ايه؟ اصل انا كان عندي الحاله دي قبل كده. تاخدي الدواء يو نيد ماني اورز ابارت لان الاسيديتي ما بتتغيرش بسرعه ترجع تاني، والافكاسي بتاع الادويه ديت كبير. فمشكله لما تبقي بتاخدي دواء مرتين في اليوم، واحد الصبح واحد بالليل، لو اخدتيها في نص اليوم يو مايت افكت الابسوربشن بتاع اخر النهار. ف it is a very difficult situation. بس تبعدهم على قد ما تقدر. يعني العيان اللي ما قدرتش اعمل معاه اي حاجه كنت يعني كومبرومايز كان ان هو يبقى 6 ساعات بينه وبين الدوز بتاعه التسجنه لو هترجعوا تحطوه تاني على تسجنه يعني.
تمام. يبقى راي حضراتكم الاول ان احنا نعمل ميوتيشن ونشوف لو هو يعني الجليفيك ستيل ريسبوندنج عليه، ممكن نزود الدوز بتاعته ونعمل له كارديولوجيكال اسسمنت عشان نشوف السورس اوف ستروك، واكوردنج الكلام ده كله نبدا نشوف هنرجعه تاني على الجليفيك بانكريزنج الدوز ولا هنمشيه على تسجن. تمام كده ولا حد ليه من حضراتكم اي كومنت تاني؟
انا شايف لا يعني البون مارو برضه ممكن يساعد، بس يعني just to make sure it's not
هو بس حضرتك في البون مارو حاليا العيان اوريدي يعني بارابليجيك، يعني هو سوري، فعشان يروح يعمل بون مارو فدي يعني مأساة شويه. فاحنا نعمل زي ما حضراتكم قلتوا اتليست الميوتيشن، وبعد كده نبقى ان شاء الله نقرر هياخد ايه.
انا فكرت ان احنا فعلا عملنا بون مارو بعد يعني من مؤخرا صح؟ اللي هو ده
لا او هو
no.
كله من اول ما تشخص العيان من سنتين يعني.
اوكي
عمره ما عمل بون مارو.
تمام اوكي
خلاص ماشي جدا، شكرا. لو الدكتور عاطف جاهز يتفضل.
وعليكم
السلام ورحمه الله.
واضح؟ معلش انا اسف على صوتي.
اتفضل. ايوه عاطف اتفضل معانا. تحب تعمل السكرين شير؟
طبعا ان شاء الله.
اوكي اتفضل.
أنا أول أعرف نفسي عاطف عينيش، عاطف شحاتة hematology specialist working now at the Egypt Air Hospital. First, I want to thank the presenting doctor and Dr. Muhammad, Dr. Sameh, and every other doctor who share their time and their knowledge with us. So we have a case here. Male patient, 62 years old, presented to emergency room with morbid fatigability. Developed a few weeks ago before presentation. Mild gastric discomfort, no other toxic symptoms, no bleeding manifestation. Examination show only pallor, only hepatosplenomegaly, spleen 5 finger, 10 centimeter below costal margin, liver 2 finger below costal margin. CBC on admission show white blood cells around 21,000, hemoglobin was 4 gram, platelet 65,000. A normal liver and kidney function, virology, HCV, and hepatitis B virus was negative. Were negative. Serum ferritin was around 1,600. The ACR was 60 and LDH around 800. Differential CBC unfortunately done after 2 backdoor RBCs transfusion and show marked normocytic normochromic anemia with anisocytosis, marked leukocytosis with mild absolute neutrophilia with shift to left, 5% band, 3% myelocyte, 5% promyelocytes, and 5% blast. Absolute lymphocytosis, marked absolute basophilia, marked thrombocytopenia with leukoerythroblastic reaction. Critics was around 3.4%. Bone marrow aspiration show marked hypercellularity. Erythropoiesis virtually absent. Leukopoiesis marked increased granulopoiesis. Basophilia around 17%. Blast 4%. Megakaryocyte markedly reduced. Conclusion picture suggestive of chronic myeloid leukemia accelerated phase. IBT done in peripheral blood, but wasn't also conclusive. Only show myeloid phenotype in around 20% of cases, 20 cells, 20% of cells. We asked for BCR able qBCR. Unfortunately, it was undetected. So we started aronisp 150 microgram per week, and hydroxyurea 50 milligram, 500 milligram twice per day. Due to compression manifestation, patient had due to splenomegaly, but we stopped it after 2 weeks due to severe progressive cytopenia patient had. After that, bone marrow biopsy came with marked hypercellular bone marrow to about 90% cellularity with feature of MBN disorder and asking for immunohistochemistry. So we revised our information about WHO criteria, about criteria of a typical CML, which show the diagnostic criteria: peripheral blood leukocytosis, more than 30,000, neutrophil precursors, more than 10% of leukocytosis, Philadelphia negative, not meet criteria of other MBN like Polycythemia vera, essential thrombocytosis, and primary myelofibrosis. No evidence of related-derived risk factor receptor, and no minimal absolute basophilia. No minimal absolute monocytosis, and hypercellular bone marrow, granulocyte proliferation, and granulocyte dysplasia with or without dysplasia in erythroid and megakaryocyte lineage, and less than 20% of blast in peripheral blood or bone marrow. We had the JAK2 mutation and CALR and MBL negative, but platelet-derived growth factor receptors weren't available. We repeat the bone marrow aspirate and the biopsy to confirm how to verify the diagnosis and show the result. And basophilia was around 26%. There was normal morphology, blast around 6%. Megakaryocyte be reduced. And the conclusion show marrow very overlapping among the different MBN disorders, and the mast cell leukemia couldn't be excluded, and ask for serum tryptase and the KIT mutation. Also, bone marrow biopsy show around 50% of cells increase in polymorph large and have a regular nuclei and folded and occasionally spindle in shape, and cytoplasm is abundant, is and eosinophilic. And the conclusion, mast cell of origin cells, as I say, mast cell neoplasm disorder. WHO criteria about mast cell neoplasm show major criteria and minor criteria. Major show multifocal dense infiltration of mast cells. Minor, more than 25% mast cells with typical morphology, what we have here, KIT mutation, CD25 with without CD2, and serum tryptase more than 20 nanogram per milli. Patient during presentation didn't have any manifestation of mast cell leukemia or any site of infiltration according to the initial radiology he has as a CT chest and ultrasound abdomen, and the examination also so, and there is no any site of mast cell infiltration, only clinical of mast cell histamine release. So we had a serum tryptase were 7.4, which is normal, and the c-KIT mutation of exon 9 and 11, 13, 17, only detected by PCR. Revision of bone marrow biopsy with the lab again. After these results, he had a reticulin stain, which show bone marrow fibrosis, coarse bundle formation, grade 4 fibrosis, and he also say the diagnosis may be MBN neoplasm unclassified. However, examination of a new bone marrow sample for evaluation of myeloid and next generation sequencing needed to verify the diagnosis. So until now, patient still in supportive treatment. Patient need recurrent blood transfusion, and only for now we need what should we do next? Thank you.
العفو. شكرا يا عاطف على البرزنتيشن. بص، في حاجه مهمه جدا علشان الفاليو بتاعت الدسكشن ديت تكون عاليه، هي ان لو ممكن نستفيد من دكتور سامر باكتر قدر ممكن كباثولوجيست معانا، هو ان احنا نديله المعلومات الرا، يعني اللي هي تديله المورفولوجي، تديله الفلو سايتومتري بلوتس، بحيث ان هو يقدر يبص عليها ويقيمها تقييمه هو، بدل ما نبقى ديبندنت على الريبورتس. فاهمني؟ فدي حته ممكن تخلي الدايجنوستس هنا اسهل بكتير. وانت طبعا دخلت في ايه، في 3 or 4 different disease processes. It is unlikely to be any of them in my mind. انت فاهم؟ بس الفكره فعلا ان الاول الحاله كانت ماشيه very pointed towards a myeloproliferative disorder، صح؟ CML very likely. بس انا هشوف، عايز برضو دكتور القرآن عنده كذا تعليق على النتائج اللي اوريدي شيرد معانا، لو ما عندوش مانع يشاركنا رايه في الحاجات ديت، وايه الحاجات اللي هو he recommends to add to might give you the diagnosis.
Sure, Dr. Muhammad. Actually, yeah, and again, like, more than happy to help you ahead of time. And I mean, thank you for putting this together. We understand, you know, this, you're not a pathology, but you know, having pathologist involvement, it would be helpful. You know, we're starting with the the CBC. The patient had leukoerythroblastosis, but the platelet count was 63,000 or 630,000.
The patient show platelet about 60,000.
60,000.
Yeah.
Okay. So how? But they are describing. Okay.
Thrombocytopenia.
Thrombocytopenia. Okay.
Thrombocytopenia. Okay. So so everything pointed towards CML, and it is true that you know, almost always the breakpoint in CML is going to be the 210, which is always the major breakpoint. However, there are, you know, rare cases, you know, that where you can have even a larger fusion protein. It can be P230, and then you know, the minor breakpoint. I mean, you know, we see it mainly in the Philadelphia chromosome positive ALLs, but you can detect some of these. And I think, Dr. Hagaz, we talked about this, but like, I need to point out that, you know, the PCR test that's available, it's only for the 210. So that's something that couldn't have been tested. But was FISH done? Because sometimes some of these cases can be detected by FISH.
No.
I mean, the limitation is with the chromosome, the karyotype, but not with the FISH.
No, unfortunately, we didn't do that.
Okay, the other comment I have, I mean, these like large pleomorphic cells, which were at one point described as 50%, and I guess that's where the emphasis was on, they were not detected in the first bone marrow?
At first bone marrow, no. The only shows this comment. Yeah, he was suggesting CML from the first presentation, first bone marrow done here.
And I'm sorry,
even the peripheral blood IBT didn't show this much.
So like, it's really difficult for me to give an opinion. I mean, if we don't have access to these images or to these slides.
I'm sorry for that.
هي ديت يعني it's a good learning process. يا عاطف what we are looking at here in a fee population of 50% on the second biopsy that isn't clear. What are they? And that's what brought the possibility of a systemic mastocytosis. But at the same time, you have other pictures of a you know, a myeloproliferative disorder going on. You know, what else is missing here? Clinical scenario does. If you're looking at mastocytosis, you're also looking at skin findings, respiratory findings, all those things. في أي حاجة من الحاجات ديت كانت؟
لا.
Okay.
لا خالص.
ما فيش.
Have no any toxic symptoms. No histamine release manifestation, no any focal collection of cells had been detected during examination.
فزي ما الدكتور سامر قال انت عندك الميجر بريك بوينت with 210 حتى في ال 210 نفسها there's multiple tests that you can do that is not fully covered there. فالفيش ممكن يجيب لك ال 190 و you can even look for 230 زي ما الدكتور سامر والدكتورة إسراء في الشات بوكس هنا قالت ال 230 maybe the most rare بس 210 has I mean ال 190 is a little bit more common even though the 210 is the majority of the CML cases.
I mean, this is definitely an unusual case. Again, like this just emphasizes the importance of a proper workup. Like so mast cells, you know, we don't test for them routinely, but you know, they can be, if this was a mastocytosis, they should be readily identified morphologically. They have a characteristic histologic features. However, you know, you can indirectly identify them. So if they, and I see, you know, I'm looking at your presentation, I guess it was just a recommendation, CD34, 117, 79, and 3,
yeah.
They were suggested, but like CD117, I just want to make a point. It's a myeloid marker. It's a great marker for, you know, myeloid lineage. But it also highlights the early erythroid precursors and also the mast cells. In the bone marrow, the mast cells have the highest intensity of CD117 expression. So not when you are interpreting immunohistochemistry, and that's where the importance of involving your pathologist in these discussions. It's not just whether the stain is positive or negative. It's important to know where it is, what it is targeting, what cells are marking with it, and also the level of intensity or the reaction can also give you an idea. So usually we just do CD117 to screen for all of these, and you know, it helps us identify the erythroid cells, the myeloid cells, and the mast cells. But it seems to be like a very unusual to be a mast cell. And as Dr. Hikazi said, you know, we're moving from one to into another. So it's really important to have you know, these histologic sections so we can focus our discussion.
لو تقدر يا دكتور عاطف تشاركنا بالمورفولوجيكال بيكتشرز بتاعه البابسي والبلوتس بتاعه الفلوسايتومتري، ويا ريت لو الحاجه دي تبقى في ايميل ونبص عليها we can then revisit الكيس دي والعيان it doesn't look like aside from severe cytopenias that developed with the treatment he's not super symptomatic at the current time, correct?
تمام.
patient
still have anemia because he didn't respond well to ABO or bone marrow stimulant, so he still need backed RBC transfusion.
Which is possibly it's not going to get better until you control the disease or whatever the process in the bone marrow. But if you can get us these pictures, that would
I will try.
That would help a lot. And عارف إن الموضوع يعني it's interdepartmental with them. You need the pathologists to cooperate علشان الحاجات دي بتحصل. بس دي الواقع يعني اللي هو يعني in order to have a good conversation ونوصل لdiagnosis ممكن تعرف we are neutral eyes. عارف سواء من الكلينيشنز زي انا ودكتور سامح او الباثولوجيست زي الدكتور سامر فجايين على الحاله فريش نبقى محتاجين معلومات اكتر عشان نقدر
نعمل. طيب هو حتى لو على ال WHO criteria هل انا اقدر اعتمد على ال two minor criteria only to diagnose the mastocytosis?
You need three.
Yeah.
Yeah. So you need 3 minor criteria. So وانت ما عندكش الميجر criteria you haven't انت ما قلتلناش ان الماست ان هم الانفلتريتس دولت ماست سيلز صح؟
Even it's mast cells. So we can exclude it by according to this data we have here.
مظبوط. We don't have enough evidence ان احنا نقول ان هي mastocytosis لا.
تمام. So we can if we only this is the only data we have and all the lab we have here. We can diagnose the case as a primary myelofibrosis.
لا ازاي؟ How are you making the diagnosis of primary myelofibrosis?
Because we didn't have we have MBM unclassified. Okay, we have minor criteria like anemia, leukocytic reaction, spleen, others, and fibrosis grade 4. And I know it's maybe reactive, but I just want to take a decision about the case.
ما هو
هو انا يا دكتور محمد رأيي هو الحاله دي يعني هي غالبا يعني هيم malignancy ومعها يمكن associated بس increase in mast cells. ممكن الفايبروسيس يبقى secondary. يعني it sounds like it's probably going to be like يمكن MPN MDS syndrome overlap. بس هو زي ما يعني دكتور حجازي ودكتور القرآن كان لسه بيقول يعني you really need to pin the diagnosis عشان بعد كده هيترتب عليه حاجات كتير. ف at this point you know you cannot make a decision about the case لأن هو diagnosis unclear. لأن هو مثلا يعني لو هو heme malignancy هو most probably heme malignancy يعني هو يعني MPN, MDS, whatever, هيحتاج some sort of like salvage therapy يعني initial induction therapy وبعديها يعمل allogeneic transplant. بس it's big decisions زي ما انت شايف. You really need to pin the diagnosis.
Yeah, if I can make a comment, please, just to answer the question. You know, we all, you know, the myeloproliferative MDS, myeloproliferative MDS neoplasms. I mean, it's really, I mean, it's like it's a clinical pathologic diagnosis and clear, but you know, the morphology can be helpful. So to answer the question, why for me, like, I don't think this is a myelofibrosis. You know, usually you see pan-myelosis. You see, like in CML, we see granulocytic hyperplasia. With my primary myelofibrosis, we see pan-myelosis. We have all the elements increased. In contrast, like we're not talking about this. And for this patient, but like in AT, you see a lot, you know, megakaryocytic hyperplasia and clustering, and polycythemia, you see erythroid hyperplasia. So the morphology can give you actually clues that can help you guide your further workup. And even like not only the what cell line is increased, the morphology of the cells can be. So in myelofibrosis, megakaryocytes have a characteristic feature, or you know, it may be difficult to recognize in all cases, but you know, they tend to have coarse lobulations. In AT, they tend to be staghorn. Even in polycythemia, they tend to be giant. So that's why it's important to look at the morphologic details. My concern is like the discrepancy in the reports. When you tell me there are 50% pleomorphic cells, I mean, that's something worrisome. It doesn't fit into any of the diseases you've discussed. I mean, even, and if you have fibrosis, I mean, anytime we have fibrosis, we always have to exclude the possibility of metastasis. And as Dr. Sameh said, you know, sometimes you see like plasma mast cell proliferations in bone marrows. And I've done it myself, where I sent specimens for c-KIT mutation, even though it did not fit the criteria, just because they are increased, but, you know, they are not spindled, they are not clusters, and the patients don't have any other evidence of the disease.
Thank you very much. Okay, thank you very much.
You are very welcome. You're very welcome. So if you can, Mustafa, I'll repeat myself again. If you can get morphological studies in pictures as well as the flow cytometry plots, share it with us, inshallah, and it might help. And as you know, the management can differ significantly. Yes, there is significant fibrosis here, بس مش that doesn't mean that it's you know a slam dunk primary myelofibrosis. It can easily be a reactive process, especially in a chronic myeloproliferative neoplasm that is ongoing. ف يعني خلينا نجمع
وصلت لهم ان شاء الله.
انا شفت الكومنت على النكست جنريشن سيكونسنج. انتوا موجود الكابابيلتي ديت ان انتوا تبعتوا الحاجه للنكست جنريشن سيكونسنج؟
لسه داخل قريب يعني، في مصر في معمل او 2 بس اللي بيعملهم.
اوكي. وطبعا في ديتيلز اكتر بقى، يعني هو ايه الكفر، ايه الحاجات اللي هم بيعملوها في النكست جنريشن سيكونسنج؟ هل هم عاملين زي يعني ايه كومبريهنسيف مايلويد بانل، ولا بيعملوا ايه؟ لان زي ما انت عارف ان النكست جنريشن يعني بيغطي حاجات كتير
كتير. للامانه ما اعرفش، لان يعني ما طلبتوش وما عداش عليا حاجه قبل كده. يعني الموضوع لسه اللونشنج بتاع مثلا معمل مشهور في مصر هنا كان لسه الشهر اللي فات
اوكي.
يعني الموضوع لسه لوكالايزد قوي.
تمام. في اي كومنتس من الدكاتره على حاله الدكتور عاطف تانية من الدكتور سامح او الدكتور طارق to shed any more light قبل ما ندخل البرزنتيشن بتاع الدكتور سامح؟
لا انا ما عنديش كومنتس تاني.
اوكي تمام.
هي دكتورة إسراء جمال كانت بعتها كذا سؤال في الشات.
احنا في السؤال اوكي، لا فاتتني الاسئله. AML.
السلام عليكم دكتور محمد.
ايوه دكتوره اسراء، اتفضلي.
ازي حضرتك؟ هو حقيقي الدسكشن حلو جدا وممتع، وانا استفدت جدا بكلام حضراتكم. انا بس كنت عاوزه اسال البرسنتج بتاعه البوزيتيفيتي بتاع CD 117، واي ثينك كان معايا حاجه تانية من المايلويد ماركرز، مش فاكره قوي من السلايدز 33 او 34 كان تقريبا البرسنتج دي 20% في الاول. فهو اوريدي احنا معانا كلو ان ده MPN. ممكن البرسنتج ال 20% بال 117 والاذر مايلويد ماركر ده ممكن يقول ان هو مثلا بروجريس AML ولا لا؟ واذا كنا نعمل السيتوجينetics of AML not only of MPN ده ممكن برضو يقول لنا اذا كان في يعني some sort of acceleration or progression to crisis يعني or to malignancy.
Good points. Dr. Samer, what do you think?
Yeah, no, to answer your question, no, because, you know, CD1, as I mentioned, like, it's important to know what it is staining. And that's why, you know, it will be helpful if we got the dot plots, because it highlights, I mean, it says we have 2 populations, a myeloid phenotype, and then a second population, 20%, showing positive for 13 and 33. I mean, 13 and 33 are also myeloid markers. So that's why it's important to identify the population. So CD117 would be positive in myeloid blasts, but it is also positive in promyelocytes. And I'm not saying like this. So, and it doesn't necessarily have to be a promyelocytic leukemia. I mean, you can see it in case where you have severe left shift is going to be increased. But where in the presentation does it say 20% c-KIT or CD117 positive cells? I missed that.
No, sorry. It was CD13 and 33.
Oh, 13,
yes.
Yeah. So these are, you know, I mean, 13 and 33, they are myeloid markers, but, you know, they are present. I mean, the cell with the highest level of CD33 in the bone marrow are the monocytes. So it is possible in monocytes. CD13 is also possible in monocytes. It is throughout, you know, like these markers are upregulated and downregulated through the different stages of maturation. So these are not necessarily markers for blasts. They
are not the same population.
Yeah. So they can see them on monocytes, and also all the mature granulocytes are going to have CD13 on them. And again, with different levels of intensity.
Thank you so much.
Yep.
Sounds very good. Good points. Good points. Thank you, Dr. Al-Quran. Dr. Sameh, thank you very much, Dr. Al-Quran and Dr. Al-Dawi, for your time and your comments, and shukran jazilan, Dr. Sameh, for putting this presentation together. And دلوقتي احنا هيبقى عندنا a review على lymphomas by Dr. Sameh Gawallah. If we can just stop screen sharing and Dr. Sameh will take over.
Okay, شكرا. هو في حاجة interesting لما باجي أعمل شير بيطلع لي زي exclamation mark وعادة ما بيطلعش طب لحظة واحدة أجرب حاجة تانية كده.
Take your time.
يمكن في security. I see. عشان الريكوردينج. اوكي لحظة واحدة، هو في security setting في زوم بيبلوك الشير لو حد بيعمل ريكورد. اوكي اوكي انا لازم اكويت وري اوبن تاني. اوكي
اوكي. It was our pleasure, Dr. Okran. Thank you very much for your time. Thank you.
اوكي نشوف بقى كده هتشتغل ولا لا. تمام. اوكي فين اوكي هل انتوا شايفين الباوربوينت ولا شايفين بس الزوم؟
احنا شايفين الباوربوينت والهول باك سكرين برضو باين وراه.
اوكي طب لو عملت كده شايف الهول سكرين؟
تمام.
تمام. اوكي شكرا يا دكتور حجازي. هي التوك دي انا اكشلي لسه مديها امبارح في كونفرنس في اورلاندو. ده كونفرنس بتاع موفد بنعمله كل سنه. وفي ابديتس للمانجمنت اوف ليمفوما ان جنرال، فوكس اكتر على ريلابس ريفراكتوري سيتنج، وفي ابديتس معظمها من الاش. اوكي دي الديسكلوجرز بتاعتي. Okay, يعني this will be like an interactive session with a case. The case, this is actually this is one of the patients in my clinic. She's 81 years old, presented with a lump in her neck. January السنة اللي فاتت. It was growing over 2 months. وكان معها B symptoms, night sweats, but otherwise was asymptomatic. Labs can be mildly elevated LDH. Otherwise, it was not very remarkable. Comorbid conditions, hypertension, hyperlipidemia, and anxiety. But the performance status is excellent. She's 81, but she has an excellent performance status. Well, the performance status, physical exam بتاعها, she did have adenopathy في النك والinguinal areas bilateral. The staging PET-CT, هي العيانة ما كانتش treated at Moffitt. هي يعني she was getting treatment elsewhere. فinitially البيت سكان لما اتعمل كان في زي ما شايفين النك lymph nodes. الاس يو فيز كانت around 5. الاس يو فيز اللي هو how intense how bright الuptake of the radioactive sugar is. It was 5 وعملوا من هناك core needle biopsy by IR, interventional radiology. ودي يعني came back consistent with low grade follicular lymphoma grade 1 2. بس زي ما انتم شايفين it was concerning لأن تحت هنا في الinguinal area uptake was much higher, it was 18. And you have to be careful sometimes if you're biopsying يعني areas that are not the most PET avid, you could miss transformation. فلما شفناها في Moffitt, we recommended a biopsy from the inguinal area, and it was very accessible. So we recommended an excisional biopsy, and this one came back consistent with follicular lymphoma, but كان في areas of disease transformation. This explains why it was very why the SUV was elevated في الانguinal area. فالclinical pearl هنا ان انت يعني you always have to confirm your diagnosis. لان يعني if you call it follicular lymphoma and you might have started with يمكن rituximab او RCDP او arbendamustine and you're missing disease transformation, she's gonna either be refractory or relapse very quickly. فالحاجة الثانية إن لو في suspicion for transformation يعني مثلا ال SUVs عالية في منطقة ال LDH super high, a lot of B symptoms, you want to consider an excisional biopsy, not a core needle biopsy, لأن the core needle biopsy is not representative of the whole node. Where Dr. Samer Henna, he might agree that they probably see a lot of these cases where they get these tiny biopsies and they're not representative of the whole node. So if you have if there's suspicion that you have a transformed lymphoma, like this patient has an endolymphoma, follicular, marginal zone, CLL, but you have a clinical suspicion and that disease transformation, no, you should consider getting an excisional biopsy. فديت الكلينيكال بيرل number 1. What's the standard of care? Standard of care has been R-CHOP for a long time. R-CHOP has been the king. It's been like 22 years. And it's not like we've not been trying to improve upon R-CHOP. There were many randomized trials. We tried dose density. So R-CHOP given every 14 days compared to every 21 days, there was no difference. 8 cycles versus 6 cycles of R-CHOP, there was no difference. Adding another agent and doing it infusionally, dose adjusted R-EPOC was very popular for a while, but then the randomized trial, the Alliance trial, came back negative. Consolidation with autologous transplant, it did show some benefit in maybe high risk diffuse large B-cell lymphomas, but overall there was no real benefit. Maintenance for Toximab did not add any benefit. R-CHOP remained king for a while. And then we started to get all these targeted agents. And the question was, could you improve upon R-CHOP outcomes with these newer agents? We tried to add Boards-Jan31, change the Rituximab to Obinutuzumab, which is another anti-CD20 agent. We added Ibrutinib to R-CHOP, added Lenalidomide to R-CHOP. All these randomized trials came back negative. It's been like a graveyard of randomized phase 3 trials. Up until this ASH. ASH in this December, they presented data from the POLARIX study, which is a randomized phase 3 trial. Accrued previously untreated diffuse large B-cell lymphoma patients. And they were randomized 1-to-1. Either R-CHOP or Pulatuzumab with RCHP. So they took out the vincristine and exchanged it for Pulatuzumab. This was done for 6 cycles, and then all patients received Rituximab on cycle 7 and 8. And so what is Pulatuzumab? So Pulatuzumab is an anti-ADCC. So it's a antibody drug conjugate. So it targets CD79B, and it's linked to a toxin which disrupts your microtubules. So when it attaches to CD79B, which is expressed on most B cells, internalized, and then basically causes apoptosis. And surprisingly, there was a decent difference. So this is after median follow-up of 28.2 months. There was a PFS difference between POLA R-CHP compared to R-CHOP. So this is the first time in 22 years that we have now seen something actually beat R-CHOP. The hazard ratio was 0.73, which basically translates to a 27% reduction in your relative risk of disease progression, relapse, or death. This is huge. Although the difference is about 7%, the follow-up is only almost 2 years. I think this is very significant because diffuse large B-cell lymphoma is one of those diseases that you want to cure upfront, because once you get to the relapse refractory setting, it gets very tricky. So even if you could prevent even 7% of relapses upfront, that's still going to be very clinically significant. Okay, يعني الستاندرد for diffuse large B-cell lymphoma هو it's still not FDA approved, but probably within very, very soon this is going to be the next standard, Pulatuzumab R-CHP, and the toxicity profile was very similar between both arms. I'm not showing you the data, but it's very similar. And the neuropathy rate, which is the biggest side effect of Pulatuzumab, it was not more than what you would normally see with vincristine. So this is huge practice changing, and it's definitely going to change our practice. Okay, back to our patient. What did we do? هي دلوقتي عندها transformed, newly diagnosed transformed follicular lymphoma. These are treated just like you would normally treat diffuse large B-cell lymphoma. So because of her age, she got 3 cycles of mini R-CHOP, and her interim PET-CT, she still had some residual disease up, in the pelvis and in the subpectoral area, but she was responding. So she got another 3 cycles of mini R-CHOP. And then at the end of treatment, it looks like she was actually progressing. And this is going to be another point that I'm going to make, because the report that we got here, if you read it, it says almost complete resolution, hypermetabolic lymphadenopathy with residual activity in the left supraclavicular lymph node with a maximum SUV of 7.9, and residual activity in the right external iliac with a maximum SUV of 15, compatible with marked positive response. So this is what I would call a trick report, because this is not a complete resolution. At this end of treatment PET, you want to see a complete CR. You want to see Duval scores. You want to see sizes of lymph nodes. So we had to review the pathology again, and the radiology again. And no, the patient, the Duval score is 5. The lymph nodes have increased in size, and there's actually a new cervical lymph node. All this is consistent with refractory disease, and this makes a huge difference. So this is my clinical pearl number 2 for you. You always have to confirm what your response is, response to therapy. It's very important to look at the Duval score. What is the Duval score? Basically, it's instead of getting these descriptive radiology reports that try to tell you, oh, it's responding, whatnot, you want to actually measure the response. So if the FDG uptake is higher than your mediastinum in the liver, then this is a Duval score of 4 or 5. And progressive disease, you're basically looking at Duval score of 4 or 5 that's actually increasing, meaning the intensity is going up, or if you have any new lesions. You always have to make friends with your radiologist. You want to talk to them. You want to ask for a Duval score, because this helps you, basically answer the question, how is this patient responding? You want to sometimes, you want to always ask for the size of the lymph nodes, because if you're not sure what's happening with your Duval score, a lymph node that's growing and it's becoming more hot, you have to find out what's happening with this lymph node. And my last point here is going to be, you never switch therapy based on a PET scan alone. Okay, so you have to always confirm your diagnosis that this is relapse refractory diffuse large B-cell lymphoma. So if you're getting a PET scan like the one I showed you, you don't switch therapies based on this, because this means salvage therapy, autologous transplants, CAR T-cell, And sometimes you'll be surprised. So you could find other malignancies, you could find other etiologies like sarcoidosis or reactive necrotic nodes. So if you get a PET scan and it's suggestive of refractory disease, you always have to confirm that this is indeed refractory disease with another biopsy. Okay, so this is my clinical pearl number 2. Okay. Back to our patient, how did we treat her? So again, now she's an 81-year-old primary refractory diffuse large B-cell lymphoma. What does primary refractory mean? It means that she did not respond to your initial 6 cycles of R-CHOP, either at the end of treatment PET, or she's relapsing within 3 to 6 months after finishing R-CHOP. These are the highest risk patients. We did repeat a biopsy, and it did confirm that this is indeed refractory diffuse large B-cell lymphoma. We got FISH this time, and it did show that she has a double hit lymphoma. So the c-MYC was rearranged, and the BCL2 was rearranged. Okay, so my clinical pearl number 3 is where to go from here. You always have to define your goal of treatment, because the way we typically think about relapsed refractory diffuse large B-cell lymphoma is we typically think about it as, okay, are these patients transplant eligible or transplant ineligible? But you have to remember, before asking that question, you have to ask the patient and have a discussion with them. What's their goal? You'll be surprised sometimes. So if you're trying to achieve a curative therapy, then yes, then you ask, you know, is this patient transplant eligible or ineligible? If they're eligible, you could do salvage therapy followed by autologous transplant. You could, if they're not responding to salvage therapy, they could go on to CAR T-cell therapy. But sometimes you'll be surprised. Some patients, you know, especially older patients, they'll tell you, doc, I don't want any aggressive therapies. I'd rather get something to buy me more time, and they're interested more in palliative treatment. And we do have a lot of actually good palliative treatments. They're not going to cure the patient, but they could provide them with a few years of decent quality of life. So Tephacimab, Menolamide is now approved for patients who have transplant ineligible patients who have received 1 line of previous therapy. Other agents such as Pola-BR, Toximab, or even clinical trials, they will usually look for patients who have received 2 prior lines of therapy. So you ask your patient, you sit down with them, what's your cure? What's your goal here? Are we trying to cure you, or are we trying to palliate you? And then you go from there. Okay. So what are the factors that we would normally consider? What, you know, for a patient, how do you determine someone is actually an autologous transplant candidate? Is he eligible or not? So age is a factor after a certain age. So we've done autologous transplants on, you know, patients who are 75, 78. But I think once you start getting to 80 and above, most people would not be eligible for an autologous bone marrow transplant, because this involves high dose chemotherapy, and a lot of patients will do well. It's very, very important to look at the performance status. So if you have a patient with a poor performance status, these are patients who are not going to be eligible for transplant. You want to look at comorbid conditions. Is this person coming in with respiratory failure on oxygen because they've been smoking all their life? Or they have, you know, heart failure that's uncontrolled. These patients are not going to be eligible for a transplant. They have to get a transplant, you have to do salvage therapy, and they have to have chemosensitive disease. The best patients will be those who get salvage and go into complete remission before going to autologous transplant. Not everybody will have access to a transplant center close by. Not everybody will have the social support that's necessary to get a transplant. And you always have to remember that being transplant ineligible does not mean CAR T ineligible, meaning that you could have someone who cannot get an auto transplant, but they could actually get CAR T cell therapy. We still look at other things like performance status, but there's issues with CAR T as well. I mean, not all patients will have the insurance coverage, the access to a CAR T center, social issues. And remember, the process takes a couple of weeks for us to collect the cells and manufacture them. It takes 4 to 6 weeks. So their disease has to be under control during this time. Okay, so how do we treat, so where's the data coming from for transplant? So back in the 90s, before rituximab, there was the PARMA trials that showed that salvage therapy followed by a transplant was better than salvage therapy alone, and you could cure about 50% of patients when you do a transplant this way. So this defined transplant as the standard of care, salvage therapy followed by a transplant in relapse refractory disease. And then in the rituximab era, we had the CORAL study. So this is the one that I'm showing you right now. So the CORAL study compared RDHAB to RICE, which are two salvage therapies. And then patients who achieved chemosensitivity, they went on to receive an auto transplant. And then patients had a second randomization of rituximab versus no rituximab. What did we learn from this trial? We learned that RICE and DHAB are equivalent. It doesn't matter which salvage therapy you're going to be using. Now we have more salvage therapies. We have R-GemOx, we have R-GDP. It doesn't really matter which salvage therapy you have as long as you demonstrate chemosensitivity. But what we did know is that the worst of the worst cases is going to be the patients on your graph C. These are the patients that are primary refractory and they received previously rituximab. So لو بصيتوا على الخط الأصفر, these are patients who had primary refractory disease and they had R-CHOP with their initial therapy. These patients do very poorly with our standard of approach of salvage therapy followed by autologous transplant. As you could see here, their PFS is like less than 20% typically. Okay. How did we proceed with this case? We spoke with her. She was interested in a curative approach. The options before this year were basically palliative Tephacimab or Menolamide because she's transplant ineligible, or for curative options, you could do salvage with R-GemOx, and if she's not responding, which is usually the case with all of these primary refractory cases, then she could go on to CAR-T. This standard will change again this year because this ASH, there was data presented in the second line setting where CAR-T was used in the second line setting from two trials, and Dr. Fred Locke from our center presented data from the ZUMA-7, but there was also data from the Transform study. I'm not going to show you the slides here, but basically patients who were high-risk lymphomas who relapsed within 12 months or were primary refractory. So those high-risk patients that I showed you, those patients were randomized to our standard, which is salvage therapy followed by transplant versus CAR-T in the second line setting, because right now CAR-T is approved in the third line setting and beyond. CAR-T showed superiority in both of these trials, in the ZUMA-7 and the Transform. And that's probably going to change the standard of care. Now, there was a third trial, the Belinda trial, which looked at Kymriah, which is another CAR-T agent, but that study was negative. So probably the approval is going to be for Axicell and Lysocell, which is what was used in ZUMA-7 and Transform. Okay. Clinical pearl number 4. Not all diffuse large B-cell lymphomas are the same. The worst of the worst cases are going to be your primary refractory cases or those who are relapsing early on. The current standard salvage followed by an auto, as you could see, the outcomes are very poor. Late relapses, meaning that they relapsed after 12 months. These are probably going to stay. It's probably going to still be salvage therapy followed by an auto transplant. And these patients have about a 50% or so of cure with this approach. الحاجة التانية مهمة قوي, and you have to think about which patients do you give CNS prophylaxis. This is a huge subject of debate, but generally there are some approved, generally agreed upon high-risk patients for CNS disease, and these you would recommend intrathecal therapy or high-dose methotrexate. I think a lot of people now are moving away from high-dose methotrexate, but these are your double-hit lymphomas, a lot of extranodal involvement, so involvement for adrenal gland, your kidneys, testicular diffuse large B-cell lymphoma, multiple extranodal sites. So مثلا عندك عيان جالك بالskin, and they also have bone marrow involvement, These patients are very high risk for CNS disease. You want to do prophylaxis. There is a CNS IPI score that you could go online and calculate it. But generally, these are the things that you want to look out for. Okay. As I mentioned, Tephacimab with Menolamide is one of the options that you could talk about with patients in the second line and beyond, as long as they're transplant ineligible. It's going to be palliative. What is Tephacimab? It's a CD19 antibody. It's a bare antibody, and it acts like rituximab, so it causes direct cytotoxicity. It could also aid in antibody-dependent cell-mediated cytotoxicity or cell-mediated phagocytosis. And when it was combined with lenalidomide, this was in the L-MIND study. This study was a phase 2 single-arm open-label study, and Tephacimab is initially given once a week for the first 3 cycles, and each cycle is 28 days. Subsequently, up to the first year, it's done twice a month. And then afterwards, it's continued, but after the 12th month, you continue Tephacimab twice a month, but without the lenalidomide. You have to bear in mind some important points about the study. The patients that were selected were not the highest of the highest risks. So patients have had to have less than 3 prior lines of therapy, no primary refractory disease, no double hit or triple hit lymphoma. So these are not your highest risk patients. And you could probably see this because the overall response was quite high for this patient population, close to 60%, with a CR rate of 40%. So this is the L-MIND study. And as you could see here, the outcomes are very decent for those who have complete remission. Their PFS is not reached. Now this is the data just presented in Hematologica last year. The median duration of response has also not been reached. Even if those patients who have achieved a partial remission, their median duration of response is also not reached. Okay, so what are the toxicities from Tephacimab lenalidomide? It's very well tolerated. It's mainly going to be cytopenias, which is something that we are going to experience with whatever therapy you give these patients. Okay, so back to our patient. So she decided to receive R-GemOx, rituximab, gemcitabine, oxaliplatin for 2 cycles as salvage, but then she had refractory disease as expected. She received CAR T-cell, which is Lysocell, and achieved remission at day 30. But then unfortunately, 9 months later, post-CAR T, she again developed rapidly enlarging lymph nodes and consistent with diffuse large B-cell lymphoma relapse. What do you do? So Pulatuzumab BR is an option, Tafa-Len is an option, Toximab is an option, or even clinical trials. And I'm going to discuss briefly what the data for that gave these medicines their approvals. You have to understand post-CAR T relapse, these patients do very poorly. They do worse even if they relapse if their CAR T relapse is early versus late, but universally patients who fail CAR T are just not going to do well at this time. Okay, so just back to the data. So Pulatuzumab, Pola-BR, so Pulatuzumab with bendamustine rituximab, this got its approval from a randomized phase 2 trial where patients who were not eligible for transplant were randomized to either BR or Pola-BR. The trial did not include any patients with follicular grade 3B or transformed diffuse large B-cell lymphoma. And the responses were very good. This was, again, just recently the results have been updated. The Pola-BR PFS was significantly longer than bendamustine rituximab with even a survival advantage. If you look overall, patients in their second line, they have an overall response of 74% with all of them pretty much in CR. If you look at third line and beyond, the overall response was 50% with 42% being in CR. What about those super high risk patients that I talked to you about, the primary refractory people? the responses were lower. It was 40% with a CR rate of about 33%. So again, these are your troublemakers, the primary refractory patients, and you can see it at the bottom here on the right. What's the toxicity for Pulatuzumab? Again, you're going to see cytopenias, but you're also going to see neuropathy. Most of the neuropathy is well managed, and it does improve with time, but that's something to watch out for. Okay, next. So we have Toximab. What is it? It's another CD19 antibody, but this one is we attached a dimerizing agent to it, a alkylating agent to it. So it's an antibody drug conjugate. And this targets CD19 where it's engulfed into the cell, and the dimerizing agent basically blocks DNA cross-link formation and causes cell death. It got its approval from the LOTUS-2 study, which is a phase 2 study that enrolled patients with relapsed refractory diffuse large B-cell lymphoma. Initially, the first 2 cycles, you're getting a higher dose, 150 micrograms per kilo. And then subsequent cycles, you're getting half that dose. And that helps significantly decrease the adverse events. In the LOTUS-2 study, those who achieved complete remission, the median duration of response was 13.4 months. So as you see, these treatments are not really curative, but they do provide these patients with time. The overall responses was about 48%, and half of them were complete responses. You don't want to compare between trials. You don't want to say, oh, the responses were higher with Pola or with Tephacimab, because you have to remember the patient selection are very different. So for Toximab, the inclusion criteria were very liberal. They had 13 patients who had CAR T before. They included patients with primary refractory disease, double hit lymphoma. So they had a much higher risky population. Side effects, so it does have the cytopenias that you would see with other agents, but also has some unique toxicities. So gamma GT you want to check for because it can be elevated, and you could actually sometimes need to dose modify based on the gamma GT. It can cause some edema and diffusions, can cause some skin rash and photosensitivity, so you want to tell your patients to avoid sun exposure. What's coming next? So it's going to be bispecific antibodies, and these are antibodies that basically have 2 domains. One domain attracts your T cell, attaches itself to your T cells, and the other domain basically would attach to the lymphoma. So it's like a poor man's way of doing CAR T, but it's in an antibody form. Currently, there's a lot of them in development. These are the ones that are undergoing more advanced phases of development now. So Mosunetuzumab, Glofitamab, Odronextumab, and Epcoritamab. They all have varying response rates and CR rates, and but the data is still in its relative infancy, and mainly phase 2 data. You can get side effects similar to what you would get with CAR T. So you can see some CRS and some neurological toxicity, although it's much lower than CAR T cell therapy. This ASH, there was data presented now with combining those bispecific antibodies with other agents like Pulatuzumab. And some of these patients had previous CAR T cell therapy. And you could see here, for example, with Mosun, you're getting responses of 60% in patients who have previously failed CAR T. Same thing with Glofitamab here. You're getting very, very encouraging response rates. But I don't think these are, again, going to be curative treatments. They're more on the palliative side, but I think it's a great addition to what we currently have. So let's look at, hypothetical, how the landscape is going to change for lymphoma. So suppose you start out with 300, patients with lymphoma. You're giving them R-CHOP right now. You're curing about 2/3 of them up front. You end up with about 100 with relapsed or refractory disease. About half of them are going to be transplant eligible. The other half will not be transplant eligible. For those who are not transplant eligible, as I showed you, the standards are you could do palliative rituximab, GemOx. You could do Tafa-Len. Pola BR, you could do it off-label. It's not does not have an FDA label here, but you could use it off-label. You could also do clinical trials. If you're transplant eligible, the standard has been to give salvage therapy followed by an auto, and traditionally we're able to cure about half of these patients. If you're not responding to salvage, so of the patients who are getting salvage therapy with a goal of going to transplant, about half of them are not going to respond, and these are the patients who should get third line, either CAR T if you're trying to cure them, or palliative options similar to before. Selinexor is also an option. I've never used it. It has a lot of GI toxicity issues. If you're failing CAR T, again, palliative treatments are an option. So what is changing and what was based on ASH? The first line is going to change now from R-CHOP to POLA R-CHP. So that's going to be huge. And the second thing is patients who have high risk relapse, so primary refractory disease or early relapse, these patients will probably get approval for CAR T in the second line based on the ZUMA-7 and Transform studies. And it's already on the NCCN. It was just changed now to the second line. And I think probably the FDA will change very soon. And that's the presentation. Batati, I'll be happy to answer any questions.
It's a wonderful talk. Thank you so much, Dr. Sameh. I'll wait for other questions, بس أنا عندي سؤال بالنسبة للبولاركس. وإحنا كنا هنعمل زي journal club project تاني منفصل عن ده, once a month كده we discuss practice changing studies and trials. أعتقد POLARIX deserves to be an article or a study to be discussed in details. بس أنا عايز أخد رأيك, هل are you changing your practice to POLA RCHP across the board, or are you doing it for the intermediate high IPI and keeping the lower ones to R-CHOP?
Hamad, if you look at the subgroup analysis, I think overall there was an advantage for POLA BR. We're probably going to need a little bit more data. We'll see what the FDA says about the approval, but my gut feeling is this is just going to replace R-CHOP and it's going to be across the board.
طيب بالنسبة للدبل هيت, I know إن النمبرز كانوا صغيرين في الدبل هيت. Is your practice continuing to be the same also, or are you going for the epoch in that?
ما هي بص هي الفكرة إن الدبل هيت lymphoma, they're not all the same. Okay. Some of them will get early remissions, and actually there is there's data, multi-center data. There was, if you look at Dan Landsberg paper in JCO, if you have a double hit lymphoma and you're getting early remission, CR, these patients actually, even without a transplant, their outcomes were not different than other diffuse large B-cell lymphomas. Your problem is going to be those primary refractory double hit lymphomas. And I don't think anything we have right now works. I've been using R-EPOCH, but I don't think there's retrospective data looking at R-EPOCH versus R-CHOP, and it doesn't look like, R-EPOCH is doing any benefit. So I'm willing to try anything, because right now, what we have for these patients does not work. I'll probably switch to POLA BR. I think probably Pulatuzumab is a better agent than etoposide.
Got it. Excellent. حد عنده أي أسئلة تانية دكتور سامح بخصوص البرزنتيشن؟ تمام. It's a wonderful presentation. شكرا جزيلا دكتور سامح على الريفيو, and it's a very exciting time. diffuse lymphoma بصراحة يعني.
One ASH, we had the first line and second line standard change. It's a really exciting time. Yeah.
That's very exciting, very exciting. Tuzumab seems to be a promising drug. شفت Pola Mosin data this past ASH برضو was interesting combination down the road. Thank you so much, Dr. Sameh, and for always making this a valuable time. أنا نفسي بتعلم كتير، فشكرا جزيلا. وإن شاء الله يعني هنحاول نخليها برضو كمان شهر من دلوقتي. We gather some cases. We'll try our best إن إحنا الحالات تبقى فيها بعض الباثولوجي، لأن ما دام الdiagnosis is unclear, we have a pathologist joining us, then we should have something for them to look at. So hopefully لو الشباب يدونا حالات معاها باثولوجي raw data للباثولوجيست قبل البرزنتيشن بكذا يوم، علشان نقدر نعمل discussion مفيدة في الموضوع. شكرا جزيلا لكم جميعا، وان شاء الله نتجمع كمان شهر
ان شاء الله. شكرا
جزيلا.
شكرا. السلام عليكم.
وعليكم السلام.